make this event come together to become a success, especially for Professor Nicholas Budiparama as our mentor and our proud initiator of this webinar. And also we would thank Dr. Zaimil Hilmi as our current IHKS president, who has showed full support. And the last thing, we are grateful for Indonesian Orthopedic Association approval and support. We couldn't have done it without you. In today's gathering, I would like to focus on our new volunteers who have joined us since the first station. You have all been chosen to be a part of our community due to mutual passion for hip and knee surgery field. We, IHKS, as a solid organization that really focus on adult recon, sport, and trauma around hip and knee, are consistently bring you the best expertise in order to achieve excellent performance in our field. Your passion help us all to unite, and the energy we create is what allows us to achieve our individual as well as group goals. We need you as much as you need us, and that's why we are grateful to have you join us here at 6 IHKS webinar series. During the next few hours, you will be learning about the patellofemoral issue, which is often forgotten in treating patients' complaints. I hope this will help you grow to be more decisive and comprehensive in treating each of our patients. Well, I don't want to take too much of your time. I need to leave some time for Dr. Lutfi to introduce our honored chairman and speakers to all of you and fill you in on some of our upcoming activities. Today will be fun and full of learning. So very warm welcome to each and every one of you. Please, Dr. Lutfi.
Okay, thank you, Dr. Ricky, for the opening speech. Now, greetings and welcome to my fellow orthopedic surgeon from Indonesia and also from around the world to our IHKS webinar series. As you know, this is the 6th and final session of our webinar series. My name is Lutfi Hidayat, and it's been an honor to be here as your co-chairman. Just for you to know that this webinar will be delivered in English. Today is very special because in the session, we're going to be filled with legends like David Dijor from France and also Dr. Sachin Tapasvi from India and our chairman, Dr. Nicholas Budiparama. We also have Dr. Andrea Nior on board. Today's topic will be patellofemoral problems. Let's make it simple. We also like to announce that today we have around more than 3,000 participants in conjunction with Ortho TV, 1,400 participants and also 1,700 with Ortho TV. We also relay this webinar in YouTube. Thank you once again for your participation. Before we start, I would like to point out again some of our regulations. First, participants need to put their real name on the screen. If you want to ask a question to the speaker, you can write it down on the Q&A column or you can raise your hand. Please do not use the Q&A column to communicate between participants. And at the end of the webinar, there will be survey or feedback and also quiz with interesting souvenir. So please don't miss it. We also like to announce the winner of last session. We have Dr. Iputu Sandi Kumara, Triksi Brevi Putri, Ali Abdullah, Chelen Setiawan, and also Andre Wahyu Wicaksono. Please stand by because our committee will contact you using your social media. And I would like to say thank you to our sponsors. For today, we have Welesta as our platinum sponsor and Menarini as our gold sponsor. After this, we're gonna see the video from Menarini.
Pain. It is the most common reason people seek medical care. Did you know, every year millions of patients suffer from acute pain, while approximately 22% of the world's population are living in chronic pain. Pain is invisible, but the burden of prolonged pain suffering impacts every area of our life. As a result, preventing us from doing what we love. Not only that, it increases the economic burden to individuals, healthcare providers, and society at large because of costs associated with the loss of productivity, delayed hospital discharge, and re-hospitalization. While we've come a long way in making a wide range of pain treatment options available in Asia Pacific, we continue to face challenges in achieving optimal pain relief. It may be due to a lack of access to the right pain medications, pain education not being adequately taught, doctor-patient relationships, social and cultural attitudes towards pain, or even genetics. These multifactorial barriers result in inadequate pain relief. We understand that alleviating pain can be a long and challenging journey, but no one should have to suffer in silence. As members of the healthcare community, we can help patients break free from pain by having better communication with them, to sympathizing with their pain, to delivering effective pain relief solutions. Every effort counts. This is why at Menarini, we're committed to working alongside you for the long term, so that everyone can live their best at every stage of life. Together, we can alleviate pain and invigorate lives.
Okay, that's a video presentation from Menarine. And before we go into the main topic, now we have our industrial sponsorship presentation by Dr. Andrea Yanuar on myofascial pain, the commonly missed source of pain. So for your information, the Dr. Andrea Yanuar is head of orthopedic and traumatology service in Saint Borromeus Hospital, Bandung. He finished his fellowship in 2017 and residency in 2008 from Hasan Sadikin General Hospital. So for Dr. Andrea Yanuar, the screen is yours.
Okay, thank you, co-moderator, for the nice introduction. So in this afternoon, I will share the presentation about the myofascial pain, the commonly missed source of pain. So myofascial pain is a form of chronic pain, and this is initiated by the biomechanical maladaptation. This can be happen in the osteoarthritis. Now become a lot of paper discuss the role of the biomechanical maladaptations, such as in osteoarthritis with the myofascial pain, and also the other paper also discuss about the myofascial component of pain in the knee osteoarthritis that we often forget it. And also in the patellofemoral problem, we also have we also can find the myofascial pain syndrome. So we also can find the myofascial pain and the facet joint arthritis, spinal stenosis, and tendinopathy. So after the biomechanical maladaptation, it will lead to the local muscle injury. And this will increase the motor end plate activity and focal hypertonicity. And we can see the good example if the patient with the problem in patellofemoral, they normally also have the weakness in the gluteus medius muscle. So as we know, the gluteus muscle is the primary dynamic stabilization of the hip and also help the external rotation of the hip. And if this muscle had weakness, then the other muscle try to compensate is the quadratus lumborum. They become hypertone, tight, and the chronic hypertonic can lead to the ischemic. And ischemic tissue will release the noxious substance such as the calcitonin gene-related peptide, bradykinin, etc. And finally, this will make the sensitization of the spinal cord and will result in allodynia and hypersensitivity as the hallmark of the chronic pain. So, over the years, a variety of treatment methods have been used to treat the myofascial. They can be divided to 5 groups. The first is medication, injection, physical treatment, postural or ergonomic correction, and treatment of underlying musculoskeletal pain generator. For the medication, it's a good idea you use as the first line treatment. You can use the NSAID, tricyclic antidepressant, and also the muscle relaxant, because the primary pathophysiology is the hypertone or tightness of the muscle. So use the muscle relaxant is a good idea to use as the first line treatment. And as we know that tizanidine is, we already know that is already well known, the muscle relaxant, which already approved also by the FDA for the spasticity and very effective for the back pain, and not only the back pain but also the other muscle tightness, as we previous state. It works by central alpha-2 adrenergic agonist by reducing the release of the excitatory from the synaptic terminal of the spinal interneuron. So as the summary, the pathogenesis of the myofascial pain is start from the biomechanical maladaptation. It can be happen in osteoarthritis, patellofemoral problem, and myofascial pain is commonly missed as a source of pain. And treating the chronic musculoskeletal pain, including the myofascial pain, needs multimodal regimen. And muscle relaxant is one of the components of the multimodal regimen. And tizanidine is already well known. Muscle relaxant is safe and effective in combination with another NSAID for treating the myofascial pain. Thank you for your attention.
Okay, thank you, Dr. Andre Yanuar, for your presentation and for your information that we don't have a discussion in this presentation, but if you have question regarding the presentation, feel free to write it down on the Q&A column. Thank you. And now let's move on to the main topic of today. For today's session, it will be led by Dr. Nicholas Budi Parama. I think he doesn't need any introduction because we all know him. But for resume, he is godfather of IHKS Global Connection Campaign. He is also our founding father of IHKS. As today, he is president of Asia, IHKS, and also president-elect of APAS. He is visiting professor from several universities in Indonesia and also overseas. And for that, please welcome Dr. Nicholas Budi Parama.
Thank you, Lutfi.
Thank you, Prof. How are you today?
Pretty good. Wassalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Good afternoon, everybody. Today, we have the privilege to have two world-class faculties to give lectures for the Indonesian hip and knee webinar. So first of all, I would like to thank Professor David Dejoux from Lyon, France, and Professor Sachin Tapasvi from Pune, India. So on behalf of the Indonesian Hip and Knee Society, we would like to thank you, both of you. And we are very grateful and honored to have expert panelists like you in this webinar and willing to give lectures to us. And besides that, I would like also to thank Professor Parag Sanchetti and Dr. Ashok Sham for their generosity to broadcast all these webinars through the Ortho TV, which all combines about, we have now more than 3,000 attendees. So I would like start by introducing you my old good friend, Professor David Dejoux. Hi, David. Professor Dejoux is a head of director of the Lyon Orthopedic Clinic since 1996, and he's known worldwide for his pioneering research on patellofemoral joint, knee ACL, and the patellofemoral joint in degenerative knee. He's currently the past president of ESCA, a European Society of Sport Traumatology and Knee Arthroscopy. He published the worldwide classifications of the trochlear dysplasia and described several original surgical procedures for it. He published hundreds of manuscripts and wrote books for patellar disorders and ACL and the degenerative. He received a lifetime award for his work in patellofemoral disorders and orthopedic by the Patellofemoral Foundations. He's my good friend who used to invite me to give a lecture as well in Lyon School of the Knee Surgery. May I give a time for you, David.
Thank you so much. And I hope that everybody's listening to me. And I will start my presentation. It's a great honor to be in your country, even if I'm still in my office. And I hope that you will enjoy the presentation. So I will start to share my screen and show you and start the presentation. The goal is definitely to understand how to screen a patient who has a patellar dislocation, how to classify and how to indicate which type of surgery you have to address to this patient. So the question to answer is, do your patient really had a patellar dislocation? And is that not only pain, but it's a true dislocation? So the question that you need to ask to yourself is, what are the risk factors to get a patellar dislocation? How could we rate them? And how they are predictive in a patellar dislocation recurrence. So we use the Lyon's factor since 1987, and now you have many articles about those risk factors. The biggest is definitely the trochlear dysplasia, and you have to know and you need to know what is a trochlear dysplasia. Then the second will be the patella alta, and the third is definitely an excessive patellar TTG. So you will get the patient history. You will have the clinical exam, which is not really reliable, but it is interesting, of course. And what is very important is to look at the different abnormalities that you can have on X-rays. So everything is coming from the study done by my father and Henri de Jour and Gilles Valch in 1987. And they did this study comparing a control population and the dislocation population. And they found some abnormalities with a statistical threshold. And this is what is important, the statistical threshold. The first is definitely the trochlear dysplasia, very important. And you find that in 96% of the patients with a patellar dislocation. The second is the patella alta, and the patella alta is measured by the Caton-Deschamps index. And the third is the excessive TTTG, which you can be measured on MRI or on CT, but the thresholds are different. So the patellar dislocation is highly correlated to anatomy. Trochlear dysplasia, you will find 96% of a trochlear dysplasia in a patient who has a patellar dislocation. You will find 30% of patella alta, and you will find 56% of an excessive TTTG. If you go to other anatomical abnormalities, the femoral torsion is definitely something important, and you find an excessive femoral torsion more than 24 degrees in 40 to 50% of the patient. The tibial torsion has no significant value, and the MPFL rupture, of course, is always present, because if you dislocate the patella, you rupture your MPFL. So the role of imaging is, with the X-rays, to detect and measure some anatomical abnormalities. And if you use a CT scan, you can quantify the different abnormalities. And if you use MRI, you can quantify, but also you have a qualitative overview of the cartilage and the soft tissues of your knee. So imaging is very important in acute patellar dislocation. If you deal with the children, standard X-rays is very important. You need to have good quality. The slice imaging are mandatory, and especially the MRI, because you will see the cartilage, you will see the trochlea, the soft tissue, the TTTG and the tilt, but you will also see some osteochondral fragment which couldn't be seen on X-rays sometimes. If you deal with adults, standard X-rays, good quality, it means with the both condyles on the same line, are very important to measure the trochlear dysplasia and the patella height. And then you will ask for slice imaging, MRI or CT scan using a specific patellofemoral protocol. And this is very important to tell your radiologist to use this specific protocol. So using CT or MRI, it's about the same. You will get probably the same informations. What is important is that CT scan and MRI do not have the same threshold, and especially for the TTTG. So don't say that 20 millimeter is excessive on MRI, because it's not 20, it's 13. 20, it's for the CT scan. So that's important. So some tricks to classify your patient, and especially the trochlear dysplasia. You have three pillars for trochlear dysplasia. The first is the crossing sign, 91 to 96%. This is the groove line which crosses the both condyle on the same line. The second is the supratrochlear spur, which is a big prominence of your trochlea, and it is exactly like a ski jump. And the third is the double contour, which means that you have a hypoplastic medial facet of your trochlea. So the trochlear classification has to use X-rays first. You will see the bump, you will see the crossing sign, you will see the double contour. But you need to add the slice imaging, CT scan or MRI, because you will see the trochlear shape and the patellar shape. So it's a combination between X-rays and slice imaging. Look at that. This is a normal knee. The Blumenstadt line follows the groove line, and this never crosses the condyles at the anterior part of your knee. So it means that you have 3 points with a concave trochlea. If you have a trochlear dysplasia, this represents the lateral facet. These represent the groove, if you have a groove, and these represent the hypoplastic medial facet. So you have those 3 points, and those 3 points will define the shape of your trochlea, which could be concave, normal, flat, or even convex. But you have to add this, the bump, which is impossible to see on the axial view. That's why we need X-rays and we need slice imaging. So you will end up with a classification, my classification in 4 grades, and the 2 biggest are the type B and the type D because of the supratrochlear spur, because of the proeminence of the trochlea. The second anatomical abnormality is the patella alta, 30% in the dislocation population. And we mostly use Caton-Deschamps index, which is the most reliable. This is this one, and it's much surgical patellar index than the Insol-Salvati, which in fact doesn't change too much, even if you distalize the patella. If you speak about patella alta, you need to also look at the relationship between the patella and the trochlea. And Bernageau, a Parisian radiologist, described this index in 1984. It was the engagement of the patella in the trochlea. Bitter described the patellotrochlear index in 2006, which is very interesting because it shows the engagement of the patella in the trochlea. And I changed a little bit this index because when you have too big patellar tilt, you cannot measure this one. So we described the sagittal patellofemoral engagement index in 2013. And it's very important because it will help you in indicating some surgery, and you will see that later. The third is the alignment, and the alignment is the position of the tibial tubercle compared to the trochlear groove. It is also the femoral anteversion and the tibial torsion, but you have seen that this is not really significant. So the tibial tubercle trochlear groove is measured with two slice imaging, and we have 56% with TTTG over 20 millimeter if you use a CT scan. If you use MRI, it's only 13, and the normal value with the MRI, it's between 8 millimeter and 13 millimeter. So it's the TTTG cannot lead to a patellar dislocation alone. It's always combined to trochlear dysplasia or patella alta. And then the tilt, it's not a primary factor, but is resulting factors of all the others. And it's because you have the MPFL tear, of course, combined to the other factors. And you see here, it's a beautiful hemorrhagosis with an MPFL rupture, and you see some fat here, and this is typical from acute patellar dislocation. So patient managing, it's a little bit different between children and adults. It's very important to know if you have low instability factors or if you have high instability factors, because in the recurrence time, you will see that you will have more recurrence if you have high instability factors, for sure. So where is your patient? The patient with no risk factors, usually they have painful syndrome, and this is definitely not surgical. If you have people with high risk factors, they will be in the population of objective patellar dislocation. It means that you have at least one patellar dislocation, and in between, you can have some risk factors with no patellar dislocation, and it means that it's mostly the contralateral side of your dislocation patient. What could be the surgical algorithm that we can propose? It will be definitely based on the anatomical abnormalities. This is what we call the menu à la carte in French. You will correct all what is abnormal. If you have an excessive TTTG measured on CT scan or MRI, you will know exactly how much you need to medialize. You look at the value that you have here, and you report that on your surgical theater. So for example, for this CT scan, it's 23 millimeter. You want to be between 10 and 15. So you have to medialize 10 millimeter. It's very easy, and you will never over correct your patient. No advancement. I'm not very fond of combine any advancement, and I don't think that it add anything. About the patella alta. Patella alta gives you some specific things. Dislocation for sure, but also some impingement between the patella and the trochlea at the lower part of the patella and the highest part of your trochlea, such cartilage damages. So it gives pain, but it gives also instability. The goal is to distalize the patella. And you have to know that when you do a distalization, it leads to an automatic medialization of 4 millimeter. This is due to the shape of the tibia, of course. So the distalization will move back your patella in the deep trochlea, and it will change the cartilaginous contact area. So the goal is to distalize. If you use the Caton Deschamps index, for example, you have this index 30 on 20, or to be a good Caton Deschamps index is to distalize 10 millimeter. And you measure that with your ruler when you do surgery. You will never get any patella infera, and you will never get under or hypo distalization and under correction. That's very important. And what is important in patella alta is also to look at the MRI engagement. Because, for example, if you have a patella alta with a positive engagement, with the sagittal index positive, if you do an isolated MPFL, it will work perfectly because the patella is engaged. But if you have a patient with a patella alta with no patella engagement in the trochlea, your MPFL will not work perfectly. And your patient will be maybe a little bit more stable, but it will be definitely uncomfortable. So this is very important to look at the sagittal engagement of your patella in the trochlea. The MPFL has to be reconstructed every time because you will restore what has been torn during the first patellar dislocation. And the MPFL reconstruction is mandatory, and it will always be associated to the other procedures. Sometimes you can do an MPFL isolated when you have a low-grade trochlear dysplasia, when you have a patella height, when you have no patella alta, and when your sagittal engagement is positive, when the TTTG is not too high, and when your tilt is not too high. So this is the good indication for an MPFL. And to my practice, I have to say that I'm not doing too much isolated MPFL reconstruction. And then we come up with the trochlea. This is what has to be changed sometimes. And we speak about trochleoplasty. This surgery is a big surgery, but of course, when you have such trochlear dysplasia with the convexity, enormous convexity, with such patellar tilt, you sometimes need to change the shape of your trochlea. And look at this patient, and don't forget these X-rays. You see the two condyles are on the same line here. You have this huge proeminence, and this huge proeminence has to be removed because it is exactly that. When you open the knee, you have this convexity major, you have no medial facet. And if you do an MPFL on this or medialization, it will definitely never work because the convexity is too high. So if you look at this operating view, you look at that, it's beautiful. You remove this bump and you see how big, how important is the proeminence of your trochlea. And if you look at total knee arthroplasty, you will never accept that. So how could you accept this trochlea, and how could you accept not to correct this trochlea to get a good result? And this is exactly what trochleoplasty does. And look at that. We have removed this bump, and when you push the trochlea, it's back to normal, and you have no more proeminence. Your trochlea is becoming flush with the anterior cortex of your femur. So trochleoplasty is a very rare indication for sure, but it is sometimes very important, and sometimes you have to do it. So you need to know about that, but you need to know mostly about what is a high-grade trochlear dysplasia. So in conclusion, objective patellar dislocation will have a surgical planning if the conservative treatment failed, and I do not do any surgery before the second or the third patellar dislocation, and if my patients do not have a high feeling of instability or apprehension. And this is what we're doing, the classical menu à la carte. It means that you identify instability factors and then you correct them one by one. This is what you have to do if you want to be happy with your patellofemoral patient, which are not always easy to deal. Thank you very much. And if you want to know more, come to Milan in 2020, because we postponed our ESCA Congress, and you will also go to the website of the ESCA to upload my latest book. Thank you very much for your attention. I hope that the communication was good.
Thank you. Thank you very much, David, for a very interesting lectures. And I forgot to mention, and if I'm not mistaken, you are the third generations of this Jour, right? Your father, your grandfather, I think your son is also orthopedic surgeons, famous orthopedic surgeons now, all of you, the family.
Oh, no, no, no. In fact, my father started orthopedic surgery in my family. I followed him and I tried to be as good as he was. But my sons, my three sons, don't want to do any orthopedic surgeries. And they went mostly on law and business.
It's better. Thank you. Thank you. And the next speaker is my brother Sachin Tapasvi, who's going to talk on osteochondral injuries.
Okay, I think, sorry, because Dr. Nico internet is lost. Yeah, I cannot find his name. So let me introduce the next speaker. It's Dr. Sachin Tapasvi. He is head of orthopedic surgery department at Oyster and Pearl Hospital, Pune. He also committee member of knee sport and joint preservation of IHKS, and committee member International Affairs and Fellowship Committee in Indian Orthopedic Association 2019. He is now president-elect of Indian Arthroscope Society, president of Indo-European Arthroscope Arthroplasty Foundation 2015 and onwards. So he also chief editors in several journal and books, and also some review from international journal. So for the next speaker, Dr. Sachin, is his screen already on? Dr. Sachin?
Yeah, good afternoon. How are you doing there?
Hi, thank you, Dr. Sachin. Welcome.
Thank you, and
Great
thank you, Nicholas, and thank you, David, for that fantastic talk. It's always a pleasure if you can share the stage, so as to say, with Professor Dujour. Every single time you hear his talk, you learn so many more new things that it's really, really important, for all of us to see what what new things there are, and it's the new learning every single day. So Professor Buddhi Parima has asked me to speak about the role of osteochondral fractures, especially with associated patellar dislocations. So I think what's important here is that it's not unusual to get an osteochondral injury, either chondral or osteochondral, and almost about 95% of all patellar dislocations will be associated with some form of chondral injuries. And these can range from small cracks in the patella to chondral and osteochondral fractures as well. What is interesting is that they may happen with contact or even non-contact trauma. So we all feel that when the patella moves out of the groove, you get a fracture or an injury. But I think what's important to understand is that you get an injury two times. First, when the patella dislocates, the MPFL will tear, and then as the patella is jumping off the lateral femoral lateral trochlea, it gets a small hit, and that's where you get the small fragment that comes from the lateral trochlea, and then the patella dislocates. But the real injury happens when the patella relocates, and during the relocation, now the inferior-medial part of the patella is impacted on the lateral femoral condyle, and that's when you have that large chunk that comes and drops off into the lateral gutter, which is where you get your important fragment. So two injuries. The femur gets injured usually when the patella dislocates, and the patella gets injured usually when it gets relocated. And that's where it lies, in the lateral gutter, which is where you need to find your fragment. We've had an excellent disposition with Professor Dujour explaining to us the various clinical and radiological signs of how to diagnose a patellar instability. But when we're looking at these small or large osteochondral fragments, we need to really look hard. So here's one such patient who had two fragments, one from the lateral femoral condyle and one from the patella, which can be seen on the lateral view, on the intercondylar notch view, and on the AP view as well. They also look like a small sliver of bone, and hence may be at times called as the sliver sign. A CT scan probably is best to demonstrate these little fragments of bone, and they will also demonstrate the size of the defect, which is important for us to look at because we will be planning our treatment based on the size of the fragment that has been involved. When you reconstruct them in 3D CT scans, you can get better resolution of symptoms as well. Most of our patients would also have an MRI scan, and here you can see very well that the fragment is lying in the lateral gutter. The medial patellofemoral structures are torn, and you have a contused small patellar fragment along with another large one that is lying within the intercondylar notch. So I think the whole emphasis was that you should not be giving up on imaging so easily, as what Professor Dujour has really emphasized. And it's important that we look at all of these to then realize as to what treatment plan we need to make. So how do we treat these problems, and how do we treat someone who has an osteochondral fragment that is associated with a patellar dislocation? You have three main approaches. The first is to remove it. So if you have a very small fragment, which is probably on the edge of the patella or of the edge of the trochlea, you can remove it without much concern. If you have a largish fragment, which is at least about 2 square centimeters, which may be on the weight-bearing area of the trochlea and which has got significant subchondral bone, then it's really important that we should fix them. The ideal time of fixation is within the first 10 days, because beyond that, the fragment starts to swell up, and then it may lose some of its subchondral bone as well, and then fixation may not be ideal. But sometimes in fragments which do not have sufficient subchondral bone and they are large in size, we cannot really fix them back, or if they come to us in a delayed fashion, we have to think in terms of repair, either by doing various techniques like microfracture or mosaic plasty, or sometimes we also need to think in terms of doing a cartilage restoration procedure. So here's one such example of a patient who had a first time dislocation, or no, sorry, this was the second time dislocation. And what you see here is that this patient had a small fragment of the inframidial part of his or her patella, which was giving locking and catching type of symptoms. And this was treated with a simple removal and excision of the fragment. There are various ways in which we can fix fragments. You can use metallic screws, you can use biodegradable screws, you can use biopins, or you can use suture fixation as well. The key is to look at the subchondral bone which is present on the fragment. If you have enough subchondral bone, then I think a fixation would need to be attempted. There are various ways we should fix it. This is a large fragment in a 36-year-old male who had a traumatic patellar dislocation. You can see the size of the defect on his radiology, and on his CT scans, you can appreciate that there is a large fragment which is lying within the intercondylar notch, and there's a significant defect on the patella. So his defect measured almost about 22 millimeters in the craniocaudal direction and approximately around 16 millimeters in the mediolateral direction. He was fixed with the help of titanium Herbert screws. The only drawback of fixing these with Herbert screws is sometimes they may start irritating the cartilage and they may require a second procedure for removal. In some younger kids, you can choose to use simple retrograde K-wires if you find that you don't want to use screws or pins, but again, they require removal. These are from one of the few earlier cases whom I've done these type of surgeries on. More recently, we've been sort of moved on to be using more reliable methods of fixation, which do not require a second surgery for removal. So here's an example of a 13-year-old boy who fell down and came with an acute hemarthrosis. He had a patellar dislocation while playing soccer with the presence of a large fragment in the intercondylar notch. The MRI scans showing the presence of the injury and the fragment that is lying down inside, and this may be a case to use biopins. So there are two different types of biopins that you may use. One are those in whom which you drill, and once you drill them, you load the biopin on the inserter. These are usually about 1.5 or 2 millimeters in diameter. You cut off the desired length, and once you've snipped off the desired length, then you impact it in with the help of a delivery tube, which then helps you achieve good fixation in the bargain. You are definitely worried about what these PLLA pins will do, and one concern is whether they will cause osteolysis, whether they will become loose, or whether they will sort of back out in a retrograde fashion and may lead to problems in doing itself. You also have other type of biopins which have a little metal trocar at the tip, so you need not drill them. You can just go through and through with the same and then just snip off the tip of the biopin from the articular surface, which then does the trick and helps you restore the articular congruity. On the other hand, in certain cases, you may choose to use biodegradable screws as well, which again will allow for the same thing. And this is one such example of another fixation, and follow-up MRI scans show good restoration of articular cartilage with a good healing response. Of late, for the last couple of years, we've changed our protocol from using metallic screws and wires and biopins, and we've started relying more on suture fixation for the same. So here's again one such example of a large inferomedial traumatic osteochondral defect associated with a patellar dislocation. And in these, we get the fragment out, prepare the bed of the patella, see how the fragment fits the best, and then we prepare the base by doing a thoracurettage, exposing the subchondral bone, making some drill holes for the biology to come out, and then we add some fibrin glue on the base of the crater, and then once we've added that, we put the fragment down, and then we have these transosseous vicryl sutures which we then tie across, which helps achieve good stability of the fragment that is being fixed. We found use to be pretty useful because once you've done that, you can very well forget about any form of implant removal, and all of these have secure fixation. Of course, it's important not to forget what Professor Dujour taught us, that you need to correct all the anatomical factors at the same time as well. When you cannot fix the fragment, you have to repair it either by doing microfracture or mosaicplasty, or sometimes you have to regenerate by doing an ACI procedure for a large traumatic patellar chondral defect. So I think to conclude, it's important that we have to diagnose these injuries early, and surgery should not be delayed in such situations. If you have smaller fragments without any subchondral bone, you can remove them. If you have larger fragments with subchondral bone, then we must make all attempts to fix them. If you have larger fragments without subchondral bone, then maybe we can try fixation or repair them. And last but not the least, if there is a delayed presentation, or if you have a non-viable fragment which is large and which needs to be restored, then we have to regenerate them. So I thank all of you very much for allowing me to be a part of this fantastic educational activity, and thank you once again.
Thank you very much, Brother Sachin. It is a very interesting, it's very lectures. Sorry, just now, you know, this is the recent technology, so it's better you don't have to this very complicated Wi-Fi. So we're gonna start with Q&A.
Okay, thank you, Dr. Nico. So we have quite a lot of questions actually,
Right.
Doctor. So I would like to point out, make them into some groups, maybe from Dr. Dejo. There are several questions about basic, for example, like from Jitendra, I think it's from India. He asking about if you do an axillary X-ray for a PFJ, it's done in 30-degree of flexion, but why not in CT or MRE, also in similar position?
Yes, when you get definitely different information, and when you do an axial view, you cannot make it in extension because you will not be able to make and do the X-rays. So it's good to make it at 30 degrees flexion because it is exactly where the patella engage, and you will not miss the upper part of your trochlea, and you will not miss the subluxation. When you go to slides imaging, most of them are done in extension, and it's the best way to be reliable. And at the beginning, when we started to do CT scan in 1987, we were doing extension and flexion, 15 degrees flexion. But the problem was the radiologist, and the radiologists are always the problem. You have to work with your radiologist and tell them that they have to be exactly at 15 or 30 degrees flexion, but most of the time it's not. So we stop doing them in flexion and we make them in extension, so it's always the same. And it's interesting because we discover the fact that you see perfectly if your patella is engaged or not, and you see perfectly if you have a functional patella alta or if it's a true patella alta. So this is the sagittal engagement.
Is it good?
Yeah. And then for another question, this is also my question. So you can, for TTTG measurement, you can do it with CT and MRI, right, doctor? So which one do you think is the best to do, and what give you more information? Because like Indonesia, maybe we cannot do both on the same times because it's gonna cost too much for us.
I would say that we have been trained by using the CT in France, in Europe, and CT is very useful because you see the two knees, you can measure the rotation of your femur, of your tibia. But nowadays, MRI is mostly the standard because most of the patients can have an MRI. It's you have no irradiation, which is good. And you can also see the soft tissues, MPFL. You can see the cartilage, and you can maybe see the bone fragment that Sachin was talking about. And if you have the software, and you have also some free software like Oros, for example, you can put the CD in your computer and you do the measurement by yourself. And you can be even more precise than what has done your radiologist. So I do MRI, and we just launched a new protocol for MRI because we can make it for both knees at the same time, and we can also measure the femoral and the tibial rotation, which is very interesting. But when you ask for an MRI for patellofemoral dislocation or disorder, just write the prescription to your radiologist, and you have to tell them that it's not an ACL. They have to go above the trochlea and below the tibial tuberosity to do the measurement. It's not focused on ACL.
David, actually, you published, I think, and because if you look at the CT, it is the TT is wider. While I think for children, it's also better to do an MRI. And have you ever had any experience with nowadays? In my house, we have this dynamic MRI. Have you ever used it before?
Because you are very lucky to have a dynamic MRI. We don't have that, and we do, but on research purposes, MRI with and without contraction of your quadriceps. So you see the patella moving laterally, but it's some static views, in fact, and we do reconstruction. It's not definitely dynamic, but dynamic is very interesting for sure, and especially for the patella alta. So you will see the J sign, in fact, in real.
Thank you. Ludwig, any other question, Ludwig, from the audience?
Yeah, actually it's quite a lot, so but I'm trying to review it. So from Dr. Sachin, maybe there are some questions. So for first dislocation, so what will your protocol for your patient actually when you decide for surgery or conservative?
So I think to the best of my knowledge, I would not advise surgery for the first time dislocator. And I would probably do surgery only if there is an osteochondral fragment. And I would then, for the osteochondral fragment, do the surgery predominantly. And since we're going in and doing surgery, I would go ahead and address the primary issue why the patella dislocated at the same time. It'll be quite interesting to hear Professor David Dujour's opinion on the same. And if we could put the question across to him as well, as to when would he advise or recommend surgery for the first time dislocator.
Yeah, what about you, Dr. Dejo? Do you have any other?
Exactly the same. I never do surgery in emergency. I never do the first time patella dislocation, and most of the time I wait for 2 or 3 episodes, looking also for the instability factors. And I will. It's a good way to prepare your patient, and you say, "Wow, you have some big instability factors." So for sure, if you have a second patella dislocation, or if you really feel unstable, we will do surgery. So it prepares the patient to get surgery. It's never good to jump on your patient and to do surgery immediately. But as with a fantastic presentation that Dr. Tapazzi did, with this huge bone fragment, you have beautiful iconography for that. Definitely you need to refix them. And I really, the last technique that you showed with the fixation with sutures going through the patella is exactly what I'm doing. It is the best. It's because you don't have any material in the patella, and you can also use vicryl, absorbable vicryl number 2, because you have a big compression and it works so well. Very good. Very interesting.
Yeah. So, Lutfi, is there any other question from the audience before we go for the cases?
Okay, for Dr. Sachin, maybe this is related to the osteochondral defect during patella dislocation. So, is there any maximum amount of defect you can reattach using pin or suture? Or do you do some stem cell to make it better for healing for the cartilage?
So I think the larger the defect, more important is it for us to reattach it if we get them in the correct time. And I think that's the important fact that all of us need to look at. So it all depends upon the size. Larger the size, larger the number of pins or screws or sutures that you will require to fix it. So the principles will remain the same. You need to use as much fixation as you need to make the fragment stable. As regards addition of stem cells, you have beautiful subchondral bone on the host bed. All that you need to do is to freshen it, drill a couple of small holes using a 1.5 K wire so that you get good bleeding. And then I usually add fibrin glue, the tissue fibrin glue, so that the whole fragment sort of coapts really well. And the sutures number 2 vicryl, as what Professor David Dujour has highlighted, tie them off on the dorsal surface of the patella, and I think that does the trick really well.
Yep. Before we go to the case presentations, I have questions for both of you. If you look at the femoral anteversions, which you have covered before in this lecturing, and how to judge for the derotational osteotomy, because we know, if you look at the literature, there's no support on how much anteversion is considered to be significantly abnormal and how much is the rotation is required. Can you give some input from David or Sachin first?
Your question is very good, and because quite a lot of people are talking about the rotation. Yes, rotation. It's important, and it may lead to patellar dislocation. But the problem is that we don't have real threshold, and as we have for TTTG, for example, in the CT scan study done a long time ago, you have seen that the threshold was something 25 degrees. But do we need to derotate the femur, which are over 25 degrees? I'm not so sure, and it depends on the other factors. And sometimes, for sure, if you have 40 degrees rotation, you will do it. But in my hands, it's very rare, very rare, and I prefer to correct the local abnormalities than going to the femoral side. But sometimes you need to.
Thank you, Sachin, if you have any suggestions.
So I think, I'm typically interested about looking at rotations, especially in someone who has got genu valgus associated with patellar dislocations. And usually in these patients, it's not just a coronal plane deformity. They have a rotational pain also associated with it. And in these patients, if I'm correcting the coronal plane, because they have symptomatic patellar instability, I will also look at the rotation and do a derotation at the same time, since I'm doing a procedure at the distal femur. But yes, as what Professor Dujour has stated, we really don't have any cutoff as yet. We always check our patients. We get them in the prone position. We want to, see how much of toeing in, toeing out they have, what sort of hip movements they have. But we all recognize and realize that these are risk factors. But what do? I don't think we really have the answer, and I have not yet sort of felt the need to do an isolated femoral derotation osteotomy for correcting asymptomatic patellar instability.
Okay, Lutfi, maybe you would like to start with the cases?
Yeah, actually, question is quite a lot, doctor, and maybe this is one last question for Professor Dujour, because so many participant has asked about the technique of tracheoplasty. Can you resume a little bit in short sentences how you did perform tracheoplasty?
First of all, the goal of the tracheoplasty is really to remove the big proeminence of your trochlea, and the indications are only concerning the type B or D. It means with the patella, the trochlea which overhang the anterior cortex of your femur. So indications are very, very few and small. The surgery will we will remove the cortex around the trochlea, and then remove the cancellous bone just under the trochlea. As you have seen on my short video, when I remove this supratrochlear bump, this proeminence. And then when you have done that, well, it could be easy. With the high-speed burr, you remove the cancellous bone, and then you are able to move back your trochlea flush with the anterior cortex. And then we fix I usually fix that with an anchor and with absorbable sutures. And if you really want, you can make it a little bit more concave. But the biggest of the biggest goal of your trochleoplasty is to remove this bump. So it's not so difficult to do. Of course, it's a high demanding procedure, but as soon as you understood that you remove this bump, even if you're not deepen too much your trochlea, you will be much better. So the goal is to understand that you have to remove this bump.
Okay, thank you. I think participants should follow you to Milan next year, Doctor, to get more.
Yes, everybody has to come to Milan.
So, Dr. Sachin, for last comment, what do you comment about trocheoplasty? Did you do it often, or is there?
So definitely, I think the only place in the whole world which will do, trocheoplasties in hundreds would be Professor Dujour's institute. I probably don't do more than maybe a dozen per year because, of course, we don't get that much, workload as what Professor Dujour's center gets anywhere across the world. So trocheoplasty is a very powerful procedure. As with any other pathology in the knee, bony correction is the most powerful tool. Just as you utilize an osteotomy when you have ligament laxity, that's the real powerful tool. Similarly, bone is a very powerful tool in patellofemoral instability, whether it be your trochleoplasty or whether it is your tibial-tubercle osteotomy. I think bony surgery is a very powerful tool.
Very interesting. So you see that big surgeons, big patellofemoral surgeons like Sachin or myself, we are not doing too much trochleoplasties. And you're doing a dozen. I maybe do 30 per year. And my recruitment is very, very special. So it means that indications are very small. And for sure, probably it's better to refer your big cases to people who know how to do it, but it's a very rare indication.
Agree. So we can continue now, Lutfi.
Okay, thank you for the presentation. I think it's very engaging. It's very interesting lecture for our speakers. Now we are going to our second part of the session, about case presentation. Before we have case presentation, before we move on, we actually have video information about our new journal. Okay, for your information, starting this year, Indonesian Hip and Knee Society is launching our new journal, the Hip and Knee Journal. So everyone, especially for Indonesia, if you have any papers regarding hip and knee surgery, you can submit to us and support us. Thank you. And continue to the next session. We're gonna have a case discussion. In this case, we're trying to cover some cases from Dr. Sachin Tapasvi and also from my colleague. And before we start, I would like to invite a few more panelists to join our discussion to make it more engaging and interesting. So first, going to be Dr. Krishna, because he is our chairman, so he's supposed to be here. Where's Dr. Krishna? Dr. Atomi, he is my friend, he's my senior. He's live next to my city and he's doing a lot of knee surgery. And we also here have Dr. Andre Yanwan and also Dr. Ricky Hutapia. So Dr. Sachin, can you show
Yeah.
us your cases? And
Thank you so much. And I think what I thought it would be really good is to make best use of Professor David Dujour and ask him some really important questions, which I feel a lot of us would have some sort of questions about. So this is, this is an 18-year-old gentleman who plays recreational soccer. He's got 3 episodes of patellar instability, and I don't want to waste too much time on all the imaging, but what he definitely has is that he does not have any of the huge risk factors. So essentially, probably this is the type of he's going to be the gentleman in whom we are going to be planning to do an MPFL reconstruction. So Professor Dujour, I think what we really need to know and understand is that what would be the preferred technique, because we do understand that MPFL reconstructions are probably the most commonly performed patellofemoral surgery. So what would be your choice for fixation in the patella? Would you like tunnels, or would you prefer anchors, or would you prefer a bony trough? And if so, why?
My preference for the patella side is not to use any material, and I don't like to put hardware on my patella. I don't like too much anchors on the middle part of my patella, because you have this bony avulsion sometimes, quite often in fact, and I feel that the bone is not so strong. So my preference is to do 2 tunnels on the anterior part of my patella. It means that I go on the cortical side of my patella, so it's super strong and I never get any fracture. And my gracilis goes through these 2 small holes and then go on the middle side of the patella, and it works well. I don't do any, and it's very cheap also because I don't use any anchors.
So you would probably say that your preferred graft would be gracilis, is that right?
Yes, gracilis, but it depends on the size of my gracilis. So before harvesting it, I'll look at the size of my gracilis, and if I feel that the size is not good, I take the SMIT, no problem for me.
Do you have any experience with using the quadriceps tendon? Taking a small superficial layer of the quadriceps and routing it under. Would that be of any use?
Yes, I tested it when I was doing trochleoplasty, because it's logical. You do a transquadricipital approach, so it's logical to take the quad tendon. But frankly, I feel that it's always too short, and I'm not using it too much.
What about fixation on the femur? So we always have this doubt. So in your technique, probably you're passing the graft to the patella first and then fixing it on the femur. But a lot of people do have this technique where they fix it on the femur first and then take the graft to the patella. So what are your thoughts on this? What do you feel is better? Should we fix femur first or patella first, or does it really make a difference?
I think it doesn't make any differences, because if you fix femur or patella first, the goal is to adapt the tension. So be able to tense a little bit more or less. So if you make a femoral tunnel, you can put some strength on your graft, but you can also make it on your patella side. So for me, no differences.
Okay. What happens when you're dealing with someone who's got open fascial plates? Where would you fix the femur in these patients?
Well, if I do, first of all, I send them to a pediatrician surgeon. I'm not doing children, and I always feel that it's not a good option to open physis patient, because when you start to dislocate your patella and at a very young age, it means that you have big anatomical abnormalities. And if you will do the MPFL, and it won't be the perfect treatment, and you could face some recurrence. So I mostly advise to wait until the growth is finished. Sometimes you have to, you can do an MPFL, of course, but you know exactly, we have different landmarks. Use the fluoroscopy, of course.
So if I give you a clinical scenario where you have a small, small kid who's about 8 years old, who obviously has got large anatomical factors like a poorly formed trochlea. He does have an abnormal TTTG, but of course we know that in such an immature skeleton, we cannot do any surgery for the trochlea or for the tubal tubercle. So the poor kid can't walk, he can't run, because his knee patella dislocates maybe 6 times or 5 times in a year. So what do you do? How can you ask them to wait till they become adults? What is the thing that you help him with in the time being?
I agree about what you're saying. And 8 years old and is very bothered by the situation. You have to do something. In those patients, quite often, you can see that the extensor mechanism is short, with a short quadriceps. So if it is the case with the habitual or permanent patellar dislocation, I try to lengthen or to release the quadriceps, make an MPFL reconstruction for sure, and do an extensive lateral release. This would be my option, because you cannot do any bony procedures.
Okay, so we'll come to the next case now.
Sorry, doctor, can I ask a few questions also for?
Sure. Please go ahead. Yeah.
Okay, for the last case, for patella tunnels and anchors and also graft choice, is it different between male and female patient, or is there any requirement?
No, same.
So,
no differences.
Yeah, and it's another question also. When you do that during the intraoperative, do you know the length of the graft you're gonna do it intraoperatively?
Well, what I'm doing is to size my graft before stitching it, and I usually, so I go. You see my knee here?
Yep.
So I put my my graft from here to measure exactly the length. Usually it's a 21 or 23 centimeter, and that's it. So the habitual length is 21 or 23 centimeter.
Good. Thank you.
Okay, Dr. Dicho and Dr. Tapasvi, may I ask, how do you adjust the tension of the graft? Should we always check the alignment of the patella by arthroscopy, or is there any tips and tricks?
So I think I use more than one check when I am doing tensioning of my graft for the MPFL. The first is that I usually keep the knee flexed to about 20 degrees of knee flexion, and I want to prevent over tightening onto the medial side. So I'll ensure that my assistant is not pulling too hard on the pulling suture, which I have done from the medial to the lateral side. That's the first thing. And you want to centralize the patella in the groove. So the first is a mechanical check. The second is that I create a central high portal for viewing, which is probably through the rectus tendon, in which I put first 18 gauge spinal needle, and then I pass the Wissinger rod, over which I slide my scope in. So I see a very beautiful sort of bird's eye view. And then when you pull on your MPFL sutures, you can actually adjust the tension to ensure that the MPFL is sitting or sorry, to ensure that the patella is sitting in the middle of the groove, move the knee and sort of, like a check rein, hold it right there and fix it. So I will use both a tactile as well as a visual feedback for tensioning my MPFL.
Thank you.
Is there any other question, Dr. Nicholas? Dr. Andre Anwar, maybe?
I'm okay. Thank you. Maybe you can proceed, Sachin.
Yeah, okay. So this is the next case. So she's a 19-year-old girl and she's got painful left patellar instability. So she plays this game of cricket for our state, and her father has brought her to me saying that she's finding it really difficult to run now. She's knock-kneed, and she's got to give up practice. She wanted to play for the national team, but because of loss of confidence, she can't train anymore. So leaving aside all the other factors, I would like to draw your attention to the fact that she's got genu valgus in this particular instance here, and she's got abnormal femoral torsion as well. So this was the probable indication which I was looking like, or which I was discussing, that when you have an abnormal genu valgus, there is a very high stress on the patella, and it wants to pull the patella out laterally. It also changes the amount of forces and the stresses that you have. Also, when you have an abnormal femoral torsion, it tends to push the patella out laterally as well. Tibial torsion does not usually cause as much problems as what femoral torsion will do. And this patient was treated with a single stage distal femoral osteotomy with correction of the coronal plane along with a derotation and an MPFL at the same time. So the question to Professor Dujour is that what would be your threshold to treat patients who've got a coronal plane malalignment, who've got symptomatic recurrent patellar instability? That's the first question. And the second question is that given a choice that you have to correct, would you do both the operations in the same stage or at different stages? And would you prefer the osteotomy done as a medial closing wedge or a lateral opening wedge? Too many questions.
Okay. So about your patient, definitely you did the best option, and it's very interesting because she had a big genu valgus. She has a little bit of excessive external rotation. But if you look to the local abnormalities, and your X-ray is really perfect, both condyles are aligned, you see that the trochlear dysplasia is not major. It's not a big trochlear dysplasia. It's probably type A. So it means that what was dislocating the patella was the femoral torsion and abnormalities. So the treatment was perfect, and I would have done probably the same. About where to correct and how to correct, for sure, it's if you do a femoral osteotomy for patellofemoral problem, the lateral side is the best because you have to go. You can do also a lateral release. You have a very clear access to the trochlea, and I do like you, and I would do opening wedge osteotomy to correct the valgus and to make a slight rotation of my femur. I do not do a closing wedge osteotomies in patellofemoral joint.
Would you do both in the same setting, I presume?
Yeah. Oh, yes, always. Yeah. Always do everything at the same time, because surgery is painful. And when you tell your patient that you have to do this, and especially femoral osteotomy, and then later something else, it doesn't work. Do everything at the same time, and it works very well.
Okay.
Sachin,
yes, sorry.
One of the panelists. Oh, sorry.
Yeah.
I saw here my good friend from Singapore, Dave Lee. Dave, are you there? Dave? Well, okay, you can continue. Maybe for another question, I would like to ask his opinion as well. Okay, Sachin, you can.
Okay, sorry. So the next question is this, which is this J sign. And I think these J signs probably are important when we look at them clinically, and they have bearing on the pathology as well. So this is a boy again with symptomatic patellar instability. He's had 4 episodes, or sorry, 5 episodes on the right side. He's got 3 episodes on the left side. And his father has brought him to me, and he's concerned as to what we should do. So my question to you, Professor Dujour, is that we all are aware that when you have a high J sign, it probably represents faulty entry of the patella in the trochlear sulcus. So in your opinion, what is the pathoetiology of a J sign?
The pathoetiology is, for me, mostly the patella alta. In fact, when you go to full extension and you contract your quadriceps, the patella disengage the trochlea and goes on the lateral side. And I like and I love to make the difference between the J sign, which is static, you contract your quadriceps and you see the patella going on the lateral side, and the patient that you have shown, which is more than a J sign. It's I call that the abnormal tracking, because he goes to extension, the patella disengage, goes on the lateral side, and then when he flexes the knee, up, the patella goes back to the trochlea. So it's even bigger than a J sign. And when you have such abnormal tracking, most of the time you have a high-grade trochlear dysplasia with a big proeminence, which push the patella on the lateral side.
So I think that's what we really wanted to know and understand. And Professor Dujour has told us that that's how you grade a J sign, as a static, or what I have written down as a J sign, which is more of an abnormal tracking. And depending upon the severity of the J sign, the treatment plan will change. So Professor Dujour has explained to us that if you have a patella alta, then the patella takes a longer time to enter the groove, and that's when the patella tends to sort of move off to the side, which is important for this large J sign to come through. And of course, when you had this individual also had a huge trochlear dysplasia as well, which was why he was bumping in. And this patient was treated with a combined procedure in which trochleoplasty, along with a tibial tubercle osteotomy, lateral retinacular lengthening, and an MPFL was done, which helped resolve all the symptoms. So I think I'll stop my screen share here, because we'll definitely want to look at the cases which I think Dr. Lutfi wants to present, and I'll hand it over to you. Thank you so very much for allowing me to present.
I just say something, Sachin.
Yeah. Yes.
You make me so happy.
Oh, that has made me very happy. If I can be very happy, then that means you made my day.
I have a question for you both, doctors.
That's probably the best thing since COVID-19.
I have a question for you both, doctors. What about hyperlaxity? Do you take hyperlaxity into account when you're deciding surgery for patella dislocation? Dr. Sachin, maybe?
So hyperlaxity is not the best thing to have, and I think to try and treat someone who's got hyperextension, and I've had these couple of very tricky patients, especially females with high BMI, with genu valgus, with hyperextension of 20 to 30 degrees, and recurrent patellar instability. I think probably those are the more difficult ones to look into. But again, I think it boils down to the principles that the Lyon School has given us, which is menu a la carte. Look at all the bony alignment, look at the abnormalities that need to be treated, correct all the osseous and the soft tissue abnormalities, and you can never go wrong, is I think what I can really sort of come to a conclusion after being a disciple of Professor Dujour for several years. Professor Dujour, you want to add anything more on what I've said? Or?
No. I don't. I look at the hyperlaxity, but I do not. I say that I try to forget it and do nothing special with that.
Doesn't bother with recovery or rehab plans or tensioning of the soft tissue? No, that's the same.
No, not really.
Okay, for panelists now, we have Dr. Dave Lee. Hello, Dr. Dave Lee. Thank you for joining us into our panelists.
Okay, we can move on to the next.
Okay, next case, we have Dr. Ratomi to present his case. Welcome, Dr. Ratomi.
Yes. Can you start the screen? Show the screen. Can show the screen, Dr. Noah.
I think you have it as also, right, Lutfi?
Yes, maybe Dr. Ratomi can give a brief information about the case while preparing the slide.
Yes, this is Dr. Lutfi can show the screen, PowerPoint, my screen.
Okay, I'll try.
David and Sachin, it's not the problem is the Wi-Fi, but we are very sophisticated in Indonesia, but something might happen.
Yeah, that's true. While Tom is getting his case up, can I put up another case so that we don't spend time sort of? Yeah, do you want to do that, Lutfi? Okay, so let's present.
I'm looking for the file. You're the savior of the day, Doctor.
Okay. Okay, so Professor Dujour, this is another patient for you. So she's a young girl. She's 11 years old. She's school going, and she's got persistent bilateral knee subluxation since the age of 4. So she's unable to run. She's unable to climb stairs. She's got loss of confidence. She's not too happy. As you see, her knee patella reduces when the knee goes into extension, and the patella dislocates when the knee goes into flexion. So exactly as what Professor Dujour did allude to, as that when the knee flexes, the patella goes off to the lateral side, and when the knee extends, the patella comes back into place, and she finds it extremely difficult to attend even school. So I think it's important that these two are two different entities. The pathology of both of them is pretty different from each other. And in these patients, as what Dr. Dujour has pointed out, the problem are the very tight lateral structures and a shortened extensor mechanism, which tends to pull off the patella off laterally as the knee starts flexing. And these, what I have attempted to treat them with is to look at the tight abnormal bands on the lateral side, release them, do an extensive lateral lengthening procedure. At times, I have released even up to the sort of mid-thigh level. You also have, I've also done in these patients, a simultaneous quad tendon MPFL, and also done a split patellar tendon transfer. So at the end of this procedure, which is a completely open procedure, you have to do 3 things which are quite different from what you would normally do in an adult. And this is the final result that you would expect to get. A lot of people would also do a distalization and an advancement of the VMO, but probably I feel that I'm not too much in favor of touching the extensor mechanism in terms of touching the VMO. So I don't do too much of that primarily. So over to you, Professor Dujour, for your comments. What would you advise? and what would you do differently in such patients?
Well, this is very interesting to make the difference between the dislocation in flexion and the dislocation in extension. So if your patient dislocate when he flex the knee, it means that the quadriceps tendon and the extensor mechanism is too short, and you have to do something on it and to lengthen it, lengthen the quadriceps, move up the patella, and combine maybe to a realignment. If you have a patella which is dislocate in extension but relocates in flexion, it means that the extensor mechanism is fine, and you just have to look at the shape of the trochlea, the MPFL, and the alignment. So this is what is important to look at, and this is exactly what you did with your cases, and it's important. But the dislocation in extension and in flexion is totally different, and the causes are different, and you have to deal with that.
One more question is that, which is not related to this case, is that how do you tackle, the morphologically abnormal patella? So you have trochlear dysplasia, you have some patellar dysplasia as well. How frequently do you need to treat the patellar side? Is it really important, and what so?
Sometimes yes, it's rare, very rare, but sometimes the dysplasia of your patella is even bigger than a type 3 Viberg, and the patella is like a ball. And sometimes, and quite well, very rarely, I do a patellar osteotomy combined. And it's a closing wedge osteotomy.
David, you do at the wedge osteotomy of the patella to put to correct it, or what kind of?
Yeah, it's well, in fact, what I'm doing is closing wedge osteotomy of the patella, and I will maybe try to show you how it is. And it works pretty. It's super simple, in fact, and it works pretty well. I fix it with absorbable sutures, and the compression and the things are good. So we don't have too much complication when we do that. So I have to say that sometimes we do so. This is what I'm doing. I don't know if you see, but yeah. I remove a part of my patella in the. It's a closing wedge osteotomy for the patella. Yes. Yes.
Oh, that's very good.
It's in my new book. I do some advertising. Huh?
Just launch it. Right.
Free advertising. Thank you so much.
Yeah, Lutfi.
Yeah, I think time is up. Actually, we already passed about 10 minutes. And for the last from discussion, Dr. Sachin and Dr. Dejo, can you give up summary for maybe for us as a new surgeon about how to deal with patellofemoral problems? Dr. Dejo?
Well, first of all, I have to say that the webinars are not so easy to manage. And you did very well, and it was really interesting to me, probably because you had very good speakers and very good cases. And Sachin, you pick up fantastic cases. Frankly, it was super because very didactic. What I would like to tell you is that pay attention when you deal with patellofemoral problem to objective signs, X-rays, and fight against your radiologist to get some good X-rays. and look at the slides imaging. So when you know imaging in PF, most of the time you will be able to understand and to address the good treatment.
Okay, thank you, Dr. Dijur. That's very good. And from Dr. Sachin, do you have any advice for us, tips for us?
So I think pertaining to the talk that I gave, I think it's important that we don't miss the early opportunity to treat osteochondral fractures, which are associated with lateral patellar dislocation. So usually these will present like any other intra-articular fracture. They'll have a sudden onset swelling. They'll be more painful than your usual, lateral patellar dislocation. So keep an eye and have a very high degree of index of suspicion, and definitely try and pick them up early, because if you do, then you will have a great opportunity of treating them at an early stage and avoiding more complex procedures later on.
Okay, thank you, Dr. Sachin. Dr. Nicholas, do you have any comment?
No, I'm okay, because maybe we still have some word from the chairmen of our webinar.
Okay, thank you. This is another good discussion. Thank you very much, Dr. David Dijur and Dr. Sachin Tapasvi, also Dr. Nicholas. Time seems flies, and thank you once again for your speakers and also all the panelists. So now for the closing, as you know that today this is our last part of webinar series, and we've done it for about almost 2 months, and I believe our chairman, Dr. Krishna, gonna have few words to share. Please, Dr. Krishna.
Thank you, Dr. Lutfi. May I, on behalf of the organizing committee, say a brief word of thanks to all faculties, participants, sponsors, and all of you who contribute this webinar series. And I'm very grateful to inform that our 6 webinar sessions have been involving more than around 10,000 participants in accumulation. I hope and I believe all of you enjoy all the sessions and bring home a positive vibes. Again, thank you very much for everything. It's been a pleasure being with all of you. Stay healthy and see you next time. Thank you.
The closing speech, I think it's time now for quiz. So we have quiz for participant. So please answer the question provided on your screen, and there will be prizes. And for information for this quiz, you can obtain it from our social media. So please follow our social media. Okay, for questions. Okay, I think it's time up for quizzes. And thank you once again for attending our meetings. And also thank you for our sponsors to support our webinar until today. We have Wellista as our platinum sponsor and also Menarini as our gold sponsor. And for next session, for next episode, we're gonna have what hits on hips. So we will discuss all about hips with more prominent speaker from all around the world, with more cases to discuss, more controversy to debate. So don't miss our next webinar. For now, stay home, stay safe, and stay healthy. At the end, once again, thank you for all participants. Please fill out our evaluation questionnaire and don't forget to follow our IHKS social media. Thank you. Assalamualaikum warahmatullahi wabarakatuh. See you in next event.
You're a falling star, you're the getaway car, you're the line in the sand when I go too far. You're the swimming pool on an August day, and you're the perfect thing to say. And you play it coy, but it's kinda cute. Oh, when you smile at me, you know exactly what you do. Baby, don't pretend that you don't know it's true, 'cause you can see it when I look at you. And in this crazy life, and through these crazy times, it's you, you make me sing. You're everything, you're every word, you're everything.
Okay, thank you everyone. Good job tip. Terima kasih semuanya.
Thank you everyone. Sorry. Please.
Oke, ya.
Lutfi. Lut. Sorry ya Lut. Aku no emergency situ baru selesai.
Mantap.
Lama.
Stay simple. Lutfi aja sampai aku.
Yuk, foto bareng yuk, foto bareng.
Ya, foto bareng. Oke. Assalamualaikum.
Are you still there, Dr. Deju? No?
Are you still there?
Udah nggak ada.
No, I think.
Udah nggak ada.
Siapa capture?
Capture, nama capture.
Siapa foto? Yang foto siapa?
Nggak bisa dapat semua, Bang.
Oke. Dulu. Terus layarnya dikecilin di scroll.
Dulu ya.
Screen cap. Oke, screen cap. Kita juga foto deh. HP.
Coba, bentar.
Thanks guys, sukses ya. Thank you.
Bulan ya.
Masih.
Masuk.
Look. Foto tadi dia. Ya.
Oke. Mantap, Mas. Terima kasih. Alhamdulillah.
Oke.
Maaf ya Allah.
Lancar banget, flow-nya bagus.
Lega.
Presentation Bapak
Aku baru selesai operasi.
Tepat waktu ya.
Lagu lagi nonton. Mas Lutfi selain apa?
Udah gitu ngomong, kok aku.
langsung bingung.
malam ini bisa tidur dengan nyenyak ya teman-teman.
Aku nelpon dulu.
Saya istirahat bentar untuk hip. Tapi katanya hip mau di-handle section sendiri.
Ini si emang partisipan akeh loh. Dada-dada terus live yo.
Nggak apa-apa, masih 400 orang.
Terakhir.
Oke, terima kasih semua.
Terima kasih para partisipan.
Semuanya.
Kita sudah menunggu dari budaya.
Oke.
Oke semuanya, terima kasih. Sampai ketemu lagi offline. Terima kasih.
Terima kasih semua.
Wishing well, and you light me up when you ring my bell. You're a mystery, you're from outer space. You're every minute of my everyday, and I can't believe that I'm your man, and I get to kiss you, baby, just because I can. Whatever comes our way, I will see it through, and you know that's what our love can do. And in this crazy life, and through these crazy times, it's you, you make me sing. You're every line, you're every word, you're everything. And in this crazy life, and through these crazy times, it's you, you make me sing. You're every line, you're every word, you're everything. You're every song, and I sing along. 'Cause you're my everything.